I am now going to hand over to Sandy to share the key findings from the new report, please, Sandy.
Thank you, Kritika. As Kritika mentioned, I'll be presenting the findings from our Play in Healthcare Week reports, which this year will focus on the causes of trauma from children's healthcare. Next slide, please. So just broadly speaking, in the build-up to this report, what we sought to find out was to understand where trauma is happening in healthcare, and also to explore how play can mitigate against and prevent this trauma. And thank you, May, you've put the link to the report in the chat. Next slide, please. Just in terms of what we did a bit of a scoping review of the literature. We also surveyed health professionals, including health play professionals, and we ran a poll with a representative sample of children and parents from across the UK. Next slide, please. So now I'm going to go through our findings. And one of the main things that we found is, it's probably no surprise, that we continue to find that children are anxious, scared and distressed in healthcare. Of the children we polled, only 11% said that they felt happy or confident going to the doctor's, hospital or dentist. And 2/5 of the children who responded said that they were anxious about going to these settings. Next slide. The other thing we found out is one of the main reasons for referral to the play team is procedural anxiety, and health professionals asking the play team to support with procedural and treatment support, as well as distraction therapy. And overall, health professionals told us that children are often anxious and scared coming into their procedures, as demonstrated in this word cloud. Next slide, please. So, because I noticed we've got a lot of NHS emails in the people who joined our presentation, I thought this year it would be really good to hear from you and find out from your experience, where do you think trauma is most likely to happen in healthcare? If you scan the QR code, you can type in your answers and you can let us know, and then we can compare what everyone thinks to what we found in our survey. Oh, we've got someone typing. Inpatient setting.
Yeah, you can leave it on each one.
Yes, Amy.
58%.
Ooh. So really seeing A&E coming up as one of these areas. Interesting.
So we were from your experience. Where do you think?
Can I please ask if people could switch off their microphones, please? Oh. Okay. So I think this gives you a broad spectrum of where people have identified. It seems like A&E is coming up quite significantly. If we go back to the slides, please. And you can continue seeing that in the app. Could I please ask if people could switch off their microphones, please? So, interestingly, what we found was that blood tests and procedures involving needles was the area that was most commonly mentioned by health professionals. And also, it was the procedure that most children identified, or half of the children identified, but it was the procedure that was most commonly mentioned by children as the procedure that caused most upset and worry for them. What I think was important to note, however, is when we polled children, actually the majority of children said their greatest worry was that it might hurt, because they didn't know if it was going to hurt or not. And 40% of children talked about fear of not knowing what is happening. And these are two things that are easily solved from providing the right support to children and young people. Next slide, please. So we also asked about positive and negative experiences, and we asked about what impact do positive and negative experiences have on children and young people in healthcare. And next slide, please. What we found from the responses is that health professionals think that both positive and negative experiences can lead to children building confidence, resilience about healthcare and treatment. However, next slide, please. A lot more health professionals feel that negative experiences can lead to anxiety, fear, distress, and even trauma. And as illustrated in that quote, even after lots of positive experiences, it takes one negative experience to undo that impact. Next slide, please. The other thing we found, which is a surprise, is that play and preparation are efficient and cost-effective forms of support to children's healthcare. The research says it. I published an article this year in the International Journal of Play, in case anyone's interested in reading it, that shows that play can really alleviate children's anxiety, their distress. Children are more likely to comply with treatment when they play, and also that leads to efficiencies with the NHS. Of the children we polled, 39% said that they hadn't had the opportunity to play, but of the remaining children, 78% had played and found it helpful. The rest either didn't know or couldn't remember. So this shows that play can have a significant impact in improving children's experiences of healthcare and also minimizing anxiety and distress and trauma. But I'm not going to focus too much on that in this presentation. I'm going to focus on, next slide, please, what happens if play is not available. I have next slide. So we also asked what happens if play is not available in different healthcare settings. And what we found from health professionals is that this gives rise to other approaches. We heard how sometimes people use avoidable general anesthetic. Approximately half of health professionals observe this at least some of the time in their setting to help children comply with treatment. And we heard this about MRIs and things like that. And now you will know that general anesthetic does come with its own risks, but it's also quite a costly intervention as well. We also heard that if play is not available and a child is really distressed, they might postpone or cancel treatment. And this prolongs the treatment, which also has an impact on that child's recovery. But also by postponing and prolonging that treatment, that can be even more anxiety-inducing and traumatic as well. And most health professionals observe this. And then we also heard about restrictive physical interventions. And 9 out of 10 health professionals had observed clinical holding. So what we know from the literature, and Professor Lucy Bray is going to speak about this in more detail. So sometimes, because of the lack of training and support and guidance around clinical holding, this might not be applied appropriately. We also asked about restraint. But before I go on to talking about restraint, we've got another poll that we would like to run with you. Where it would be really interesting to hear from you if you have observed the misuse of clinical holding and or restraint. And if you scan the QR code like you did before. So far we're seeing as we're seeing from the people who are here today, that majority of people have at least seen it sometimes, if not often or very often. But also there's a few people who've never seen that, which is good to hear as well. One question that we didn't ask in our survey is, where have you observed this happening? So I'm going to move us on to the next poll. We would love to hear from you if you using the same QR code. Where have you, of those who have observed it, where have you seen what is happening? Treatment room? Blood clinic? Interesting. So that's really interesting. So some of these areas that are coming up are some of the areas where we've already identified are where children are most anxious and distressed, which is perhaps not a surprise. So I'm just going to move us on to the next slide, but thank you for highlighting that, because that's really interesting. And the fact that some people also said the anesthetic room is really interesting as well, because that's one of the procedures that are used to help children comply with treatment. All in all, what we're finding is actually, if play does not happen, this gives rise to other potentially harmful interventions, which can have a negative impact, not just for that child, their families, and Pravina's going to be talking about that in more detail about what that looks like. But it also can have an impact on efficiencies for the NHS, because a lot of these procedures mean that treatment will take longer, require extra resourcing, and so forth. But what we heard from parents and children is that roughly 10% of children and young people are at risk of developing trauma associated with healthcare due to being held down. And this is from a representative sample for the UK. So if we were going to use that to estimate what that would mean for the population, that potentially could be 1.4 million children and young people across the UK. We heard from 9% of parents that their child had a negative experience because they were held down, for example. We also heard from 8 in 10 health professionals surveyed that they had observed the use of restraint. So this is not even clinical holding, this is restraint, which again should, according to guidance, should only be used in events where a child is at risk of significant harm or significant harm to others, and usually used in secure settings. So next slide, please. What we're recommending is that there is a specific children's health action plan for babies, children, and young people to include a strategic intervention to ensure the fullest possible adoption and implementation of the Play Well Toolkit, which we published earlier on this year, and which the NHS published earlier on this year in partnership with us. And then we have a series of recommendations of how that happens. So next slide, please. If you'd like to read more about our report and what we found, there's a link there. We've also put the link in the chat. I'm now going to hand back to Kritika.
Thank you so much, Sandy. That was very insightful, and I would really encourage colleagues to read the report in full. Clearly, a webinar, we cannot cover all of the detail, but there are some very, very compelling findings in that report, and I really would encourage you all to read it and comment on it and give us your feedback. And now I'm going to invite Professor Lucy Bray to just share her reflections with us, please.
Thank you. And thank you for the presentation, Sandy. These conversations require bravery. These conversations can be quite uncomfortable. And I think it's really important to recognise that and to recognise anyone on the call that this can feel uncomfortable. And we hope that there's no upset being caused to anyone present. I'm just going to talk a little bit about my reflections of this. Can I have the next slide, please? Really, real privilege to be part of this. So the reflections on the report are that it's a really welcomed and a really important addition to the evidence. So we know, and I think it's really important to acknowledge that many children do have positive experiences of healthcare. Healthcare professionals every day deliver extraordinary and very skilled care to children and young people, but unfortunately not all children have positive experiences. We know that having a procedure, entering to hospital can cause children high levels of anxiety and distress, and I think the report shows that. We know that children and their parents report not being prepared enough or having enough information. And as Sandy says, these are very simple things to try and address. You know, how do we provide children and families with information so that they can prepare themselves? The report really clearly shows that children and parents are concerned about children being held down, and how we use restraint and forceful holding of children in healthcare, and how we don't often acknowledge this. So we talk about restraint, we talk about physical restrictive interventions often within mental health settings, within the care of children and young people with additional support needs. But we don't always talk about this within general paediatric care. It's a slightly unspoken part of what we do because it is uncomfortable. Despite the fact that we know that children being held, this can cause long-term impacts. So not only do we have a child that is distressed and resistant in the moment when they're having a procedure done, but children and parents often take these negative healthcare experiences forward, which means they do not want to come back. They do not want to come back through those doors. And their parent often can take a child home with them being really quite distressed and not understanding what on earth happened. So these are really important findings. Sometimes within healthcare services, we may think a child was not brought, did not come, and we don't always investigate what's behind that reason. And in some cases, there's really valid reasons for not coming back to a service where they've experienced harm. The report shows really nicely what we know from practice, and unfortunately, due to the constraint of resources, normally referrals through to play specialists and health play specialists only happen when a child has already got procedural anxiety. So we've written about the need to get it right first time, every time. But unfortunately, children often only make it to really targeted therapeutic approach when they've already had a poor experience and additional help is needed. We know when children have fear and anxiety and they lack trust, this accumulates every single time. This gets worse often for children, and it takes lots of effort to try and undo that and re-establish trust. Can I have the next slide, please? I think the recommendations in the report are really important. I think it's really important that we stress that play services, but also playful approaches from all members of the multidisciplinary team have an important and integral role in how we provide children with healthcare. We know that play makes children's healthcare better, and that people need to be held account for how are we providing child-centred care and how are we providing children with access to play. Quite often, when I'm out in practice areas, I will hear some professionals who will say, oh, well, we're not doing that because we don't have a play specialist here. I really welcome in the report that it's recognised that this is the responsibility of all multidisciplinary paediatric team members. So just because a play specialist isn't there doesn't mean we don't play and provide playful approaches and playful resources for children and young people. Whilst that higher level of skill and expertise is so important in health play specialists, it's everyone's responsibility. Really important to see how this report and how we are providing child-centred care aligns with the 10-year plan. So quite often what we see is that children are becoming traumatised, becoming resistant, and this is leading, as Sandy says, to more resources being able, whereas if the child had just had really good support right from the beginning, that child would be more able to link into public health programmes, more able to access healthcare, and these are really, really important for how we think about a child's health and well-being as they grow up. Can I have the next slide, please? It's very difficult to talk about this in 8 minutes, Sandy. It's a bit unfair, really, but try my best. Thinking about how we do change now and the importance of webinars like this and reports like this raising the profile of how important it is. We know there's never going to be enough money and resources. That shouldn't really be an excuse for not providing child-centred trauma-free care. We talk about there being a slow adoption of evidence in the NHS. We talk about it often taking 17 years for evidence to make its way into practice. Well, goodness me, we're not doing very well, because when you look in the literature, where over 30 years people have been writing about the need to stop restraining children for non-urgent procedures. Over 30 years. And I would argue that practice doesn't look that much different in how we really support children when they're having procedures. So why is it so difficult? So this report is great. It helps provide extra light on the need for this systemic change, and a systematic, sustained change that can't just sit with one person, but is everyone's responsibility. But I was just going to take the last 2 minutes of the presentation just to quickly, of course, talk about iSupport and how iSupport aligns with this really important report from Starlight. I'm going to go on to the next slide. And the next one. Thank you. So the iSupport rights-based standards were launched in 2022, and these are standards for the care of children who are having tests, treatments, examinations and interventions, and these are based on children's rights. So these are not just things that would be nice, but these are children's rights when they are accessing healthcare services. They look at the short and long-term physical, emotional and psychological well-being of children. So again, this is thinking about in the short term, we might decide to do the blood test today, but let's be clear on the long-term impacts of maybe holding a distressed child. The standards propose an approach to minimise anxiety, distress and harm. Really importantly, they challenge the use of restraining holds for non-emergency clinical procedures. And I had a really interesting conversation with Sandy where the terminology and the language and the definitions and boundaries of holding are really messy within clinical practice often. And I think this has been a real issue. So the rights-based standards look to really clearly define so staff have a clear idea of what is supportive holding and what is a restraining hold, moving away from the term of clinical holding, which from experience and research is used to cover every kind of holding, which was never its original intention, so that staff can be much clearer as to how they are boundarying what they are doing with children, and they're brave enough to name that and document it and offer debriefing and support to families that have experienced it. Can I have the next slide, please? The rights-based standards are 6 principles. Can I have the next slide, please? Well, I only have a minute left, so I'm speeding up. There's a QR code at the end to a link to the support standards, and they're all there. But these are looking at how we support children from before they enter services right through, attending to their rights for information, choices, communication based on their abilities and preferences, and how we support them to have a really trauma-free experience. Can I have the next slide, please? But the responsibility doesn't just sit with one person. So we've worked really carefully to write copies for families, for children, for professionals, because it requires everyone that's in that room at that time to be fully signed up and on board with how they support children to have a positive experience. Can I have the next slide, please? But we know when we speak to clinicians that they can actually really struggle to know where to start, can struggle to change, which is why we're 30 years on and things are not that much different. So we've worked with children and parents and professionals to design some audit tools that we can go along to practice areas and audit practice to help us see the things that require changing, what's leading to children having this experience. How can we be brave enough to really focus on actionable changes to make children's experiences better? Have the next slide, please. So lastly, thank you. I've put a QR code link there to iSupport, but also a link to a short film that I made with some young people where they talk about the long-term impact that experiences of trauma can have on them, lifelong impacts from poorly managed procedures. So thank you very much. Yeah, thank you. I'll hand over now to Paul, I think.
Thank you, Lucy. That was so interesting, and for sharing so much research with us, and the frustration there as well about why is this taking so long? Why is this taking so long? So, and I think it's right for us to be angry about this, because while the discussions are happening, children are being impacted on a daily basis. Thank you, Lucy. I'm going to invite Paul now to share your reflections with us, please, Paul.
Okay, yeah, thank you very much for Starlight for giving me the chance to talk about this report and what it means to us as play staff. A lot of work's been done in recent years demonstrating how important play is for children and young people in healthcare. But the evidence in this report, with data from selection of different groups across 4 surveys, proves just how vital play is in preventing healthcare-related trauma in the patients we work with, and how the absence of play leads to more trauma happening. I know that trauma that children and young people experience is something, unfortunately, that a lot of us have seen as play staff. I've certainly seen it in my role as a health play specialist over the years. And considering the number of patients who continue to be referred to us with the negative effects of healthcare-related trauma. This is something that is still sadly happening all too often, which I think these statistics prove. As a health play specialist, I've seen patients experiencing this trauma, and I've seen patients who are experiencing the after effects of it. I've also experienced it personally, as I'm sure many of you have. I went through a lot of healthcare interventions throughout my teens, some of which definitely affected me negatively and affected me well into adulthood. I know just how deeply embedded and long-lasting the effects of trauma in healthcare can be on physical and mental health, and how they can go on to change how we experience healthcare, not only in childhood and adolescence, but well into adulthood as well. So it's something that affects the adults we work with as well. As play staff, we're often working with the parents and carers as much as the patients. So we need to be aware of the mental health and the well-being issues that parents bring to the process through trauma from their own negative healthcare experiences, as well as their children's. It's really important to look at how play input can help the whole family, parents and siblings, as well as patients, in reducing both trauma and the effects of trauma. The statistics shown in this report back up the experiences I'm sure we've all had as play staff. A lot of referrals I have are for patients who have developed anxieties through trauma from previous negative experiences, from mismanaged blood tests or a rush procedure or a bad experience of clinical holding. And like the report says, one bad experience can cause a lot of fear and anxiety in the future. But the flip side of this is that one positive experience can be the first step in improving a patient's confidence and resilience. Where one bad experience can cause a lot of trauma and anxiety, similarly, one good experience could be the start of a journey to recovering from that trauma. And it can be a journey to building up resilience to deal with any future trauma as well, not only in healthcare, but in other areas of our lives. As play staff, we should be at the forefront of enabling and encouraging those first steps to having more positive experiences through play. Because as this report shows, play is the most powerful way of preventing trauma. One of the issues that we've already mentioned, that Lucy mentioned, is about restrictive physical intervention. A certain degree of clinical holding is sometimes necessary in patients, but only if done appropriately, with the consent and best interest of the patient in mind. When this is done wrong, then clinical holding becomes more like restraint and does undoubtedly cause trauma to patients. This is a common reason that patients are being referred to play staff, to try and undo the trauma from mismanaged clinical holding. Play involvement right from the start of any interaction is the key to reducing this. I think a common experience we've all had as play staff is being called in to help with a patient long after a procedure started, when the patient's already got upset and been traumatized. That is so frustrating and still happens all too often. Our part in remedying this as play staff is essential. We need to keep on educating other staff and promoting our role so we can be front and centre in guiding the whole team in their interactions with patients. We have to be able to provide play which is preemptive and preventative, not just reactive. Play input which is put in place before a procedure starts and not left until after the child's got upset or traumatized. I really think that prevention is an important word here. There's a shift in healthcare generally to focus on prevention of health issues rather than reacting to symptoms, as the report suggests. This needs to be the case with play. I strongly feel that play is a preventative medicine that can reduce healthcare-related trauma. As play staff, we should be seen as prescribers of play, literally playing a central part in the patient's journey from the very beginning of their care and treatment. If we can do this, we can make a big difference in reducing, if not eradicating, the trauma that children and young people experience in healthcare. One of the most important things here, I think, is good communication. Communication with other staff we're working with, as well as the patient and family, and engaging and interacting with the patient to try and provide them with a more positive experience. Through involving the patient in decision-making and talking to them and their parents and carers about the best way of supporting them, we can hopefully reduce the instances where negative experiences are causing trauma in our patients. Good communication can help this, and as everyone here knows, the best form of communication with children is play. Another of the issues mentioned in this report is trust. For me, trust is such an important part of the work we do. If we gain the trust of a patient and their family, then we can support them far better through their healthcare journey. Trust goes a long way in reducing anxiety and the effect of negative experiences, as well as reducing how often these occur. But of course, when patients experience trauma in healthcare, then they can lose trust in the process. This is where we come in as play staff to try and prevent getting to that stage. If we can encourage and develop trust in the patients we see and their families, then we can reduce trauma, not only for the patients now, but moving forward into future healthcare events and well into adulthood. I firmly believe that the positive long-term effects of the play we provide can not only help reduce the effects of traumatic experiences now, but can also improve the experiences that patients have in the future. Another area that the report looks at is unnecessary sedation and how play is not always being seen as a viable alternative to it. One example of this that springs to mind from my own practice is the input I've had with our MRI department. Over the past 5 years, I've built up a good relationship with staff at our new MRI unit. And through that contact, the MRI staff have seen how effective play input can be in reducing trauma in paediatric patients having MRIs, especially as far as sedation is concerned. This has led to my input being written into the protocol for paediatric MRIs here in Bronx Hospital. It now says that where appropriate, play input should be tried before any sedation or GA. And that's what's been happening. All paediatric MRIs in my hospital are now being referred to me to offer support and prep to, and as such, we're now successfully carrying out, I'd say, at least 90% of our MRIs without the need for any sedation, let alone a GA. It can still be hard work sometimes. Some medical staff who aren't as enlightened about play still try to insist on going straight for sedation and bypassing play. But with evidence like this one backing us up, I know we can find it easier to hold our ground and insist on play input being used first as a preventative measure before any other interventions. As play staff, we don't always get the recognition we deserve, and play is often misunderstood and seen as a poor relative of other healthcare services. Embedding play into healthcare can be a difficult task, but it is essential. Play needs to be not only given more importance, but set in stone as being one of the first lines of support for children and young people in hospital. Negative experiences can undoubtedly cause trauma in patients, but this can be at least minimised, if not prevented, by the input we have as play staff. The trust we can build up with patients and their families is invaluable. And we also need to trust ourselves, to trust that we can make a difference if we're given the opportunity, to trust in the play that we provide, and to trust the importance of the work we do. By putting together this report and all the data that it provides, Starlight's once again championing the power that our playful approach to healthcare can have. This can benefit everyone, patients, families, and staff, in reducing the trauma that our children and young people experience in healthcare. Whilst play is, like I said, a preventative medicine, it's also healing. Play can prevent trauma from happening, but it also heals traumas already experienced. This is where our power lies and where we can show the real value of the work we do as play staff. With this evidence from Starlight backing us up, our input as play staff is going to be invaluable in reducing, if not preventing, traumatic experiences, and in healing the traumas that our children and young people experience in healthcare. Thank you.
Thank you so much, Paul. Thank you for sharing your long experience from the front line, working directly with children, and the impact you've seen of play. Thank you so much. Please put your questions in the chat, get ready to ask questions and any observations you may have as well of all of our speakers. I am finally going to invite Pravina, who's a parent of a child who's experienced healthcare. And Pravina, we're really looking forward to hearing from you, your reflections on the report that we've launched today. So over to you, Pravina.
Hi, thank you for having me this afternoon. I am a mother of my children. My daughter 3 years ago had a very traumatic experience, which unfortunately has taken years and years to try to combat the stresses and daily anxiety that she has around her lifelong condition, which is juvenile idiopathic arthritis. So if I rewind, 3 years ago, my daughter became quite unwell, and it was necessary for her to have some blood tests done, which were unsuccessful. The restraint used at that particular time was acceptable because I was sitting next to my daughter, and there was a nurse who was trying to withdraw blood with the supporting nurse just to observe. However, unfortunately, she was unable to go ahead with the procedure because she just simply couldn't withdraw any blood. So after 5 minutes of waiting, we then had 2 new nurses coming into the room with a consultant who my daughter hadn't even been introduced to, but they said that it was so important for the bloods to be taken that it would be necessary to make sure they were done at that particular time. So my daughter had obviously built up all this anxiety, knowing that the first round had failed, and was quite petrified to have the second attempt done. And I was just shocked as a parent because I was asked to stand aside. One of the nurses had proceeded to hold my daughter with her face turned in the opposite way of where she was having a blood withdrawn from the opposite arm. The second nurse was holding her arm straight. While she was doing that, the consultant was going to take the blood, and the nurse who was holding my daughter had proceeded in wrapping her legs around my daughter's legs, holding her other arm and her face, to the point my daughter was actually screaming and crying. And whilst the bloods were being taken, she fainted. For me as a parent, I froze, because it just made me feel helpless, and I felt really, really guilty in putting my daughter through such a traumatic experience, which I knew was necessary, but the way she was held and restrained just made me feel that I was being kind of a part of her being in such a difficult situation. It was like watching your child being abused, which is not something obviously that was happening, but it was just unnecessary, the restraint that had happened. After my daughter had had her bloods taken, she was very upset, hysterically crying. The nurses and the consultant said, "Thank you very much, you've been very brave," and proceeded to walk out. And I had to deal with my daughter, who then again fainted in my arms. And she just, when she came round, she couldn't breathe. She'd had a panic attack. Unfortunately, due to that experience, she's had 3 years of trauma with every single appointment that she has had to go to at any hospital setting, or even at the GP surgery. She's guarding when she's been, examined. Due to that negative experience, she has panic attacks, palpitations, tummy pains. She's angry with me as a parent, which is very, very difficult, because when your child has a long-term condition, you want the best healthcare for them. Sorry, I'm getting upset. But in order for them to have that treatment, you don't want to see your child suffer. You want them to be able to go to a hospital setting where they can enjoy having the treatment because they've built such a good rapport with play therapists or their consulting team, and to be told in advance that there is a possibility that you may need to have a blood test. There is a possibility you might need steroid treatment. Via a joint injection. And all of these it's been a roller coaster ride for us as parents, to the point where my husband now cannot attend these appointments with us because he hates seeing his daughter so upset and traumatized. At the moment, we're in a better position because we've built such a brilliant rapport with Sophia's play therapist, and he has been amazing. One of the play therapists that we see on a regular basis, she actually helped Sophia with a plan to help her have a procedure done, but it helps her wind down and be prepared of what is actually going to happen. So it entails a bit of play, a bit of, guessing games, and, just making the appointment fun. But also as a parent, I can kind of relax a little to know that my child is not having a panic attack before having a procedure done. She's at ease. She's actually feeling brave and courageous to have a procedure done. And then after the procedure is done, she's not just sent home. She's actually, is celebrated that she's been so brave and courageous. And this is what healthcare is all about. I think that the previous experience that she'd had in the beginning was avoidable. And unfortunately, we've just wasted, I feel guilty because as a family, I feel that we've wasted a lot of NHS funds in trying to help her mental health to get to the point of where it has been today, because we've seen clinical psychologists and, counsellors, but nobody has been as successful as a play therapist because everything is so clinical and they forget that they're dealing with children. And children should be allowed to be children in any setting. So, I can't express how important it is for the findings that Starlight have found today in how to avoid trauma for families like ours and to make future healthcare and appointments a lot easier for children where they're not growing up to be traumatized adults who are then petrified of following up on, certain appointments and having care in the future. And I'll pass back to Kritika.
Rowena, thank you so much. Thank you for sharing quite difficult experiences. I was choking up just listening to you, so I can't even imagine what it must have been like to go through that. And thank you for being so brave and courageous yourself by sharing that with us today. Thank you very much. So we're in very, very good time. Thank you to all the speakers who have really, really gone through your experiences and shared them with us so well. We have time for any reflections, for any questions, any observations. I can see some of you, but not all of you. So please, if you could virtually raise your hand if you want to make a comment. I'm also inviting Hannah, one of my colleagues, to just pick up any questions in the chat as well. So we do have time. Any questions, comments from anyone? Hannah.
Hello, thank you. So in the chat, we had a comment from Lucy when Sandy asked her poll at the start about where in healthcare trauma is most likely to occur. And Lucy was mentioning any setting where children are not listened to and they have no control over what is happening to them. Also, apologies, Christine, that you haven't been able to see the slides. I saw Sandy said this is recorded, so it'll be popped on our website. And then there's a question from a couple of attendees about what is the difference between clinical holding and what does it look like and how that compares to actual restraint.
Sandy, do you want to pick that up or do you want me to pick that up?
Do you want me to pick that up?
I
Yeah,
would say
Lucy. Yeah, please,
Lucy's
Lucy,
the
you can pick
expert.
that up.
Yeah, so I popped a link into the chat because I think this is absolutely the crux and was the departure point of iSupport, really, in the fact that everything that we would do within paediatric practice would be called clinical holding. And Parvina, unfortunately, I think what happened with your daughter there, we would say we needed to use clinical holding, where clearly that wasn't clinical holding, that was restraint, and a very difficult experience for yourself as a parent and your child. So we started off iSupport by trying to clearly differentiate what was a supportive hold and what was a restraining hold, so that the practitioners and professionals, anyone working with children, were really clear on how that differentiated, where supportive holding is one where a child is calm, secure and settled and is not resisting what is happening. Anything else is restraint. And we hope that that would just help people see and be brave enough to say, either let's stop because we're now slipping into, because of course we know what starts as a comforting and supportive hold can often then progress to a restraint. but we hoped that it would help people just recognise when one becomes the other, and be brave enough to recognise when a child has been restrained, so that families can be debriefed, so that Parvina families are not having to leave a hospital feeling uncertain about what happened, feel unsupported about what happened, feel that no one's really interested in what happens next time. You're the parent that has to bring that child next time, who's supporting you to have those conversations at home, and to bring that child next time. And I wonder if those doctors and nurses often never see your child again, so wouldn't know the impact of that particular procedure on your daughter. They would never know that. And therefore it just means that we don't see that as an error and we don't learn from it, unfortunately.
Thank you, Lucy. Can I also add that any kind of intervention where a child is held down should be a last resort, should be an absolute last resort. And I just want to quote something that Paul said, which is that play should be used first as a preventative measure before any other intervention. When there is so much evidence that indicates that play can calm children down, can reduce our anxiety, can help the whole family, can help professionals, helps everyone to just achieve the final outcome for that child. When we know that works, there is so much evidence to show that works. Why are we not using that first? Why are we absolutely not using that first to make sure that we can deliver the best health outcome for that child? And so I think that's whilst of course the definitions are important, it's holding a child down should not be the first place we go. Paul.
Yes, thanks. Yeah, so obviously I agree with that completely. I mean, about play being the first line of defense really to helping reduce trauma. But also in my experience, I think with your experiences, Parvina, it's the aftercare as well. Sometimes there's been times when things have happened and it's not been an ideal situation for various reasons. But a lot of after the procedure's done, and even if it's been really stressful, a lot of the time staff disappear. Medical staff, nursing staff, it's gone. The parents are left there. And one thing I found is really important is for me to stay with families afterwards and kind of have a debrief and talk to them about how they felt that went, and talk to the patient and give them time to diffuse a bit, and then try and talk about how we can actually help and improve on this next time, or how we can support them better next time. So it's very important beforehand. It's also very important afterwards as well to try and support those families.
Thank you. Thank you, Paul. Any other comments or questions for our panel? Hannah.
Sorry, yeah, another one's come through in the chat. Oh, sorry, this one's actually a comment, but about when children have additional needs and some don't understand and play doesn't help, but children need to stay still for their port access.
Do you want me to comment quickly on
Yes,
that?
please, Lucy. Yes, please.
How else do we help? So I
Sandy.
think, oh yeah, sorry, go on, I'll just go quickly first. So I think we know that some children require additional help, need additional support, requires additional planning. And so sometimes holding may be used positively, but it's how we mitigate. So whilst we may be holding a child, if that has been decided as the best approach with really purposeful, careful planning, how do we mitigate any harm around that? So how do we support the parent and support the child as much as possible while that is happening? But I think also some countries do use, we talked about sedation and that we shouldn't be using, sedation, but sometimes sedation works really well for some children and young people if used safely and used appropriately, and is the right thing for a particular child. But it has to be associated with really careful, thoughtful planning, being careful of how we mitigate any harms within that particular experience. And we don't always do that as well. Often we just kind of jump in and hope for the best, and it's necessary, but it's not necessarily like that. How can we make that a more positive experience?
Thank you, Lucy. I've just spotted a comment from Gemma in the chat. Is some doctors and anaesthetists feel they are restricted to timings for theatre and clinic slots, and what we found, they opt for sedation or hold and do blood rather than take time for play. as feel this takes too much time. As play, I feel like if professionals don't understand it, then they don't use the play and how procedures can be traumatic for them and create long-term trauma. And this is so important. It's the practicalities and reality of actually what's going on in that health setting. But it's so important to understand that any rush to treat that child, which then leaves long-term trauma for that child, is actually not helping that child or family or the NHS. And as Pravina shared her example, taking the time to support that child and that family is actually, it's better all round for the child, for the NHS, for health professionals. So actually it's not the good option. It's not the right option. In terms of rushing it, so just so that you can get the bloods when you leave a child traumatized, and then that problem will continue over and over and over again. So it's not the right solution. And I think we all need to be shouting loud about it and sharing our expertise and experiences to influence this debate. I've got Christine and then Sandy. Christine.
Yes, I just want to comment. This is such a useful presentation. It's so much it parallels my experience as a clinical psychologist that works with children through play before they need to go for procedures or after they've experienced difficult trauma, having a medical procedure. I think I really agree with what people are saying in terms of this rushing and thinking like an adult instead of thinking like a child. And I'm not saying it's going to work because I haven't dealt with exactly the situation of where you need to put a port in. So I generally have experience with cleft palate patients where the little people need to go for all those procedures in their mouth. With the dentist. And I think play needs to happen prior the procedure. And obviously, I don't want to go into detail because I mean, it's a play therapist treatment plan. But I think the child needs to get an understanding from a child's perspective according to their age, which is very different depending on what the child's age is. So, for example, when one of the colleagues now said, that the child doesn't know how to sit still, I think the child needs to be prepared for that in a playful way. So, for example, and I'm not saying it's going to work because I've never had this example in my experience, but it would be a case of how to, for example, in play, learn how to be a superhero that has to keep dead still. And, like playing statues when we were children, and then practicing that time frame, whether it's 5 minutes and what happens if you have to do it again. So I think children need exposure to the procedure, but in a playful way. And what I've done in previous situations, often it's important to help the specialist know the playful frame ahead of the procedure. So, for example, I will send a kind of playful frame to the specialist. This is how you're going to frame the procedure for the little person in a playful way so that they're not resisting and not getting anxious. And obviously, you can't necessarily do that for you can't write a protocol for every single separate child unless you need to. But over time, the practitioner learns how little children think. And then that becomes their understanding. So the pediatrician or the specialist who works with the children says, okay, this age group tends to understand blood tests like this. And this is my playful approach. This is my warm approach towards this age group. And over time, it becomes easier. Yeah.
Thank you, Christine. That's really, really helpful. And Starlight is doing a lot of work with multidisciplinary teams to share those techniques, those playful techniques, so all health professionals who come into contact with children have an understanding of how to work with the children in a playful way to achieve the ultimate aim of ensuring there is good treatment and a good experience for those children. So thank you for your contribution. We now have 2 minutes left. Sandy?
I'd rather give those 2 minutes to anyone who wants to make any other comments or has any other questions.
Sandy, if you've got a comment, please, and then I'll wrap up.
Okay. So just a reflection on what a culmination of what everyone has said. You know, we talked about how children are often do not understand what's going to happen, don't know what to expect, and are afraid it won't hurt. And I think with play, it's not just like one type of play. There's different approaches to play that you can use. And if it's not working with that child, then there might be other techniques and approaches that might help with port access. For example, we piloted VR. What we found with VR, particularly if children had used it multiple times, they were able to build that resilience and that confidence to undergo treatment. It's about identifying what works best for that child, and what you said right at the start of the chat, Lucy, about listening to what children have to say and what makes a difference to them, and what is important to them. And core to this is actually listening to what children have to say and what makes a difference to them. And I know it seems like with some of these procedures, it might be a quick win to hold children down, but what you'll find is that leads to further problems in future, either by them being even more terrified next time they come or avoiding treatment altogether. And that goes into adulthood, and that leads to further problems in terms of people's relationship with healthcare, them seeking treatment when they need to, which then might deteriorate their health. And then that might be, if we're going to play the cynical
Thank you,
card.
Sandy. We've now hit our time. Thank you so much, Sandy.
I was just going to finish that sentence to say that leads to more inefficiencies and be more costly to the NHS.
Thank you. Can we go to the next slide, please, Hannah? So before we finish off, I want to thank our speakers who've really, I think you'll agree, have contributed greatly to our knowledge in this area. So thank you, Sandy, for the presentation, for Lucy, Paul and Pravina for sharing such insight from your own experiences. It's been incredibly valuable. And I just wanted to share this final slide, that today was the first of our webinars for Play in Healthcare Week. Please do join us at future webinars, and do share this with your colleagues as well. I hope that you found that interesting, and do follow up on our Starlight website. We will be sharing recordings of all these webinars on the Starlight website, and I look forward to seeing you at future webinars. Thank you all. Thank you very much. And to Hannah and May for helping to make this a much easier task for me. Thank you very much. And see you all soon. Thank you. Bye-bye.
Bye.